Hi Harish, how are you?
Thank you.
So what's the time there? 12 o'clock?
(12:45). I think there's some problems with my connection. I can't see. Has it started? I can't see any video.
Oh, okay. No, we're just waiting.
Okay, you're just waiting. Okay, all right. Okay, all right.
Morning, Robin.
Hi,
Jared.
How are you?
Hi.
Good, thanks.
Yeah, thanks for joining. Yeah.
We should change the host.
So you're in Cal Lab, huh? Dr. Dhruv.
Yeah.
Okay.
Not the lab in the lecture theater.
Lecture theater, okay.
Some of the old folks are here. Hi, Harish. Hi, Robin.
Hi, Dhruv.
Hi, Dhruv.
Hi.
Have you finished blowing on your spectacles?
I'm trying to look. I'm trying to look scientific.
Nah, that'll be difficult. Sorry. Sorry. There must be lots of people listening. I shouldn't say these things.
I'm sure a lot of them will be used to this.
Achha.
Hello. Hello. Good morning, everybody. Hello. Is my voice audible there, Dr. Jarrett?
Yeah.
Okay. Good morning, everybody. Welcome to the Grand Round. Over 5 billion people around the world, they lack access to safe, affordable surgical care. And Global Surg is trying to improve surgical outcomes through collaborative research. And today we have Dr. Dhruv Ghosh, who is the Hub Director for India, who is going to speak on surgical scientists using data to improve patient care. Dr. Dhruv is our own graduate, postgraduate, and faculty. And before we start to speak, I request Dr. Jairaj to give an overview about what is happening in the research and, welcome Dhruv on behalf of the medical college. Thank you.
Thank you, Dr. Ashish, and good morning, everyone, and welcome to this grand round. If you look at any intervention, either in the medical side or surgical side, people do very large-scale trials. It's very unlikely, for an intervention of a small size, for example, in 100 patient, 200 patient, that will change the practice. So you need to have adequate number of patients to test any intervention in phase 3 trials in humans. So it is a very difficult task, particularly to recruit 2,000 patients, 5,000 patients, 10,000 patients to see an effect size of about 5% difference between intervention and the control arm. So one center can't recruit all these patients. Even within a country, it is very difficult to recruit more than 500 or 600 patients for a particular trial. So that's where the global collaboration comes into play. And in the medical side, there have been many networks and collaborations, particularly to execute and implement large-scale trials, clinical trials. But however, in the field of surgery, it has been late, but there is tremendous work through the Global Surgery Group, funded by NHR from UK, with collaboration of University of Birmingham, Edinburgh, and Warwick, and CMCL-Global. We were very fortunate to join this a great group of collaborators in the area of surgery. And it's a privilege to welcome Dr. Dhruv Ghosh, who is the Hub Director, and he was our former Associate Director at CMCL-Global. And he has almost gone into full-time into this endeavor of coordinating large-scale, multiple, not single trial, multiple surgical trials across the world. And CMCL-Global has been very fortunate to be part of this great group. And the way it is growing, it's amazing. And they have got continuous funding for another a good number of years, about 4 to 5 years, and with a different goals and objectives. So with that, now I welcome Dr. Dhruv Ghosh for this grand round. So.
Thank you, Dr. Jairaj, for those very kind words. And good morning, everybody. And it's lovely to see a lot of people, a lot of good friends, old friends from around the world who are here. Thanks for either staying up late or waking up early to be here. I'm going to speak a little bit about global surge in India and how we are developing a new breed of surgical scientists which use hard data to improve care, data which is generated by us and analyzed by us here in India and many low and middle income countries. The Lancet Commission on Global Surgery was first put into place in 2012, and the last Lancet Commission report was in 2019. There are some stark figures that have come out through the Lancet Commission on surgery. Some things that many of us who are non-surgical people or not working in LMICs or what we call the Global South are unaware of. As of 2019, 5 billion people lack access to safe and affordable surgical care. Now, this is before the COVID pandemic hit the world. And so you can imagine how this number would have increased with hospitals unable to provide surgical care and certainly not able to provide safe and affordable surgical care, not just in LMICs, but also in high-income countries. About 143 million additional surgical procedures are needed each year to save lives and prevent disability. 33 million people face catastrophic health expenditures due to payments for surgery each year. So these are numbers which not only impact the health of a patient, but the livelihood and the economics of a country. There is a substantial deficit in global research focus on surgery. For many years, surgery has never been the focus of global health research or global health funding. And this research capacity is, this low research capacity it increases exponentially in countries with greatest need, that is the low and the middle income countries, especially the low middle income countries. It is amazing that there are more post-operative deaths than malaria, tuberculosis, and HIV combined across the world. Post-operative deaths constitute the third largest cause of death after ischemic heart disease and stroke. I'm not sure how many of us realize that. I did not when I first started working with our research collaborative. We tend to remain in our cocoons and we don't look at the big picture, and the big picture is not very good right now for surgery and surgical outcomes. Surgery has often been described as the neglected stepchild of global health. Neither in research nor in health programs has surgery ever been kept in the forefront, received any funding, or policymakers have looked at surgery. Surgery has been considered that's very expensive and it's not economically feasible to have surgery as a global health program. Safe anesthesia is the invisible friend of the neglected stepchild. So surgery and anesthesia, both of us are Cinderellas of global health. And I think, I'm sure in many of your centers, you do realize that surgery and anesthesia go hand in hand. One cannot do without the other. Research in surgery is critical. Like I said earlier, 5 billion people have inadequate surgical care. Now, there has been a massive growth in surgical infrastructure, especially in middle-income countries and in some low middle-income countries like India. There has been a huge growth in surgical infrastructure, surgical technology, surgical abilities. And there has been a rapid growth in surgical practitioners also in some countries. However, this is being dwarfed by the massive growth in populations which are in need. So what happens is there is a risk of overstretching resource that lowers standards of care and increases patient harm. The benefits of research are quality assurance in surgical care, engaging the surgical community to improve patient outcomes, and eventually create future surgical leaders across the world. Surgery is, I think in India, is not considered one of the top specialties, which it was a few years back, to take up after you finish medical school. And it's about time that needs to be changed, as I will try and allude in the next few slides. I will try and give you a bird's overview of what global surgery is and the work that we have been able to, both in Ludhiana as well as our friends and partners across the country. So what is global surgery? Global surgery is a multidisciplinary field which aims to provide improved and equal surgical care across various health systems. And it's not just, it's just not limited to a single health system, say within a country or just a country health system, but across the global south. We have three pillars which define global surgery: the need for surgery, the access to safe surgery, and the quality of surgery. And global surgery engages a wide range of individuals, both academicians, clinicians like surgeons, anesthetists. And when I talk surgeons, I speak of all surgical specialties: obstetrics and gynecology, orthopedics, head and neck surgeons, ENT surgeons, etc., etc. It is amazing to see that the cesarean section is one of the most commonly done procedures across the world, and it is a surgical procedure which has one of the least accesses in the global south, especially in sub-Saharan Africa, etc. The other people that it involves is politicians, economists, and patients. And global surgery, like all surgical research and all clinical work in surgery, the patient should be at the centerpiece of whatever we do. When we started Global Surge, we've thought about working on a hub and spoke model. And this is just very lightly touching on what we are today. There are 6 hubs for Global Surge. Global Surge is a research collaborative which started with the University of Birmingham, along with partners in Edinburgh and Warwick. And with the objective of working on surgical research to improve outcomes in low and middle income countries. We are now having 6 hubs across the world. You can see the hubs in Africa, in Rwanda, in Nigeria, South Africa, and Ghana. And then in Central America, Mexico, which sort of works to improve care in Central and parts of South America. And then the Asian hub, which is situated in India, in your institution here in CMC Ludhiana. We started work with global surgery, with the Global Surge Research Collaborative sometime in the late 2018. And in early 2019, we were awarded a funding to build a hub in CMC Ludhiana, as well as to develop spokes. We had some training sessions with our partners, both from Birmingham, as well as mission hospitals, rural hospitals, and other big tertiary hospitals in India. And that's when we started working towards building a hub. The person who, when I started, the person who sort of partnered me was Parvez Haq, who's your professor and head of surgery right now. And once we were trained, then we started building a collaborative across India. And we started with 6 hospitals. We always felt that the rural hospitals, there's a lot of surgical work being done, but that data never comes out. The rural hospitals don't get a voice, especially in the global research field. And it was a conscious decision to work with a rural hospital, especially CMC Ludhiana having a very good network of partner mission hospitals. And you can see we training the mission hospital researchers in Chinchpada. There's Deepak Sampson, one of our graduates and postgraduates, who's the medical and surgical director there. Our teams spread out across the country to train people both in research ethics, research methods, data collection, etc., to start our projects. And then we also worked with big tertiary hospitals, and on the top you can see the team from CMC Vellore, where Rohin Mittal heads that team, and the team from CMC Ludhiana standing next to him, where they went to train the surgical department in our research endeavors. When we started, like I said, we had 6 centers. One of the pins is in Himachal Pradesh, in Manali with Philip. The hub in Ludhiana, we had a center in Delhi, which is like an urban rural hospital. We thought in St. Stephen's. We worked in Madhepura, in Vellore, as well as in Chinchpada, in the border between Gujarat and Maharashtra. We also thought that surgery is not something that can be isolated, and we need to work with other specialties. And slowly we started building a team which was broad-based, both surgical and surgical specialties, OBGYN, oncologists, radiation oncology. Pamela has been working with us, and lately Ashwin. Microbiology, pharmacology, and of course anesthesia. And then we had other ancillary departments like biochemistry. We even moved to dentistry, where we have a very important member in our team in Ritu, who manages and does a lot of administrative work in the hub. And then our final target, students. We felt that one of our objectives was to train the next generation of surgical researchers. And we consciously again targeted students. And if you look at the lower corner, you can see 3 pictures of students and interns who have worked with us, both as research associates or research fellows in our projects. And Susan up there has actually led a research project on her own. And over the last 1.5 to 2 years, we have started broadening the collaborative, involving tertiary hospitals, big institutes like the All India Institutes of Medical Sciences, the various Christian medical colleges, PGIMers in Chandigarh and Pondicherry, government medical colleges. And we were very, very surprised to see the hunger for doing good research projects in many of our teaching institutions. It was a surprise that randomized control trials, for me, it was a surprise that randomized control trials hardly happen in surgery. And even the best institutes in India, there were no randomized trials happening. So the level of evidence was based on audits or experimental research. We involve urban rural hospitals like St. Stephen's, rural hospitals, mission hospitals. We have started working with an organization called Jan Swasthya Sahyog in Chhattisgarh, which is that hospital is an eye-opener. It's a bunch of surgeons from the All India Institute who after graduating went there and started working, and have been doing phenomenal work in that area. We've worked with cancer hospitals, and Robin is here from Tata Medical, one of our early partners. We've lately started working with the Tata Memorial Hospital in Mumbai. We've also worked with Adyar and Kidwai, and now with private medical colleges in Manikpal and especially in Amrita in Cochin, where the research output is something to be seen. And as we broadened the collaborative, we reached out to friends, old colleagues. Ashwini, who's the head of surgery at Government Medical College in Patiala, he's our graduate and postgraduate. And then friends who wanted to be part, like the Kalpana Chawla Medical College, where Parvez went and started spoke in Karnal. And that's how we sort of started broadening the collaborative, to the extent that now we work with 30 partner institutions from the initial 30 partner institutions across the country. Our research portfolio, I'm not going to go into major detail, but our research portfolio right now, as Dr. Jairaj alluded, consists of a wide range and a large number of projects. And the COVID pandemic itself has given us an opportunity to do a lot of research in surgery during COVID and after COVID. We've also felt that doing research projects, publishing papers is not enough. And as we go down this PowerPoint, I'll be able to tell you how we've tried to change things beyond just getting ourselves published in journals. FALCON was our first randomized control trial. It was one of the first surgical randomized control trials designed together by international and collaborators in the United Kingdom. We randomized more than 5,000 patients in just over a year. During the pre-pandemic phase, we were randomizing more than 1,000 patients a month, and we continued that recruitment through the pandemic. We opened this trial in 54 sites in 7 countries across 3 different continents, and we closed FALCON recruitment 9 months ahead of schedule. So you can imagine the scale of the need that is there among surgical researchers. All of this data was monitored very carefully by the Data Monitoring Committee situated in the United Kingdom. We are presently have analyzed the data for FALCON. FALCON was a 2x2 trial which looked at medicated versus non-medicated sutures and chlorhexidine paint versus betadine paint. Unfortunately, I cannot tell you the results, but it is something that is not going to please many of our multinational companies. And we hope to be we hope to be published very, very soon in one of the good journals in surgery. Our second randomized trial was slightly different. It was a cluster randomized trial. Unlike FALCON, where we randomized patients, here we randomized hospitals. We looked at whether interventions like separate sterile gloves and instruments to close wounds at the end of clean, contaminated or dirty surgery would decrease the incidence of surgical site infections. 64 hospital sites were planned across the world to randomize into intervention or standard practice. We've already up to 66 hospital sites. So the enthusiasm among surgeons, especially young surgeons, for doing this kind of research is growing. The sample size is 12,800. In India, we launched the end of June 2020. There are 22 sites working in India, out of which 6 have finished recruitment. CMC Ludhiana was the last one to finish recruitment. The other 16 sites are still recruiting. Our sample size was 4,000. We have already crossed more than halfway of our sample size, and we expect to close this trial at the end of this year, which is about a year ahead of schedule. We have also worked with our anesthesia partners and looked at perioperative respiratory cares and outcomes of patients undergoing abdominal surgery, and Penguin is one of them, which looks at chlorhexidine mouthwash before intubation, as well as compares 80% FiO2 intraoperatively versus 30% FiO2 intraoperative, see whether there is a reduction rate of postoperative pneumonia as well as surgical site infections. And we look at the economics of these interventions as well. The most important unanswered questions in research is trial retention, how to retain patients in the trial. And for us in surgical trial, the follow-up is extremely, extremely important. Unless we do a follow-up, we will not know whether our interventions are actually making a difference on the ground. With COVID and prior to that, and the fact that we work in diverse countries, in different situations, in different parts of the world, in different parts of India, in rural, urban-rural conditions, it became, we realized very early that for patients to come back for an in-person follow-up on the date that they are supposed to do it becomes a bit difficult. And then COVID hit us, and that difficulty was magnified. So we have started looking at the feasibility of and the accuracy of a telephone-administered wound health questionnaire to look at we assess the surgical site for infections after abdominal surgery. And we have started comparing this with an inpatient follow-up, and our results are going to be out very soon for TALON, which is a sort of a sub-study for FALCON and Cheetah. Which will let us know whether we can use a telephone-administered wound health questionnaire to assess patients, and patients do not have to travel large distances. You would realize that in many countries, in many low and middle-income countries, patients have to travel huge distances to access a surgeon. For example, in Tanzania, on an average, a patient needs to travel about 120 kilometers to get to a surgeon. One of our other thrust areas was of cancer, and CRANE is one of our planned cluster trials for cancer and nutritional intervention, especially low-cost nutritional intervention to improve outcomes after cancer surgery. And Pamela has led that the initial pilot here, what we call the WP3 package, which sort of identifies and validates nutritional screening tools. And from this, we finished this, and we now are in the process of identifying low-cost sustainable interventions across various countries and various regions to see whether we can do a cluster randomized trial with nutritional intervention. The sample size for the pilot was 200. One of the countries, Zambia, pulled out, and Pamela and her team contributed 100 patients to this initial pilot with time, and we should be looking at the results of this pilot very soon, as and when the other countries catch up with us. We also started looking at expenditure. It was not only about surgeons, how we are performing in surgery, but also the expenditure and referral pathways, patients' presentation and treatment. And Crocodile is a very innovative and a first-time study that has been done in the world. It's never been done elsewhere. It's being done only in India, and it's being done by our people here in Diana, Pamela, Ashwin, Parvez, Srijit, one of our very young assistant professors, along with a collaborator in the UK. And we are working now in 5 centers across the country, looking at identifying the proportion of colorectal cancer patients who suffer catastrophic expenditure due to out-of-pocket payments. So we're looking at both, it's a mixed method study, looking at both quantitative and qualitative assessment of the expenditure, seeing what their income is with very innovative tools. And so we determined then the proportion of patients who are compliant with their treatment at 6 weeks, 3 weeks, or 6 months after diagnosis, and therefore identify barriers and solutions to colorectal cancer treatment compliance. We hope to have the results. We were on a sample size of 200. We are more than 150 now, and we hope to have the results very soon. So we have big cancer centers like the Tata Memorial working with us, Tata Medical Center, as well as All India Institute in Rishikesh, and our sister institution in Vellore, as well as us. This has been one of our major successes. Susan devised a study looking at patterns and treatment outcomes, and she was finally a medical student at that time, in abdominal tuberculosis in children, which we felt had started increasing over the last few years. She did present this and apply for funding to the Indian Council of Medical Research, but unfortunately they did not choose her. She is a very persistent girl, and she continued with this. And when Global Surg came along, so she presented it to the team in Birmingham, and she was funded to a tune of almost £15,000 to conduct this study and lead this study. Susan has since finished her internship, moved on to Tezpur Mission Hospital. So Vishal is helping in finishing the study. We are at the stage of data analysis and statistical analysis, and we are looking at not just publishing a clinical paper out of this, but there have been offshoots in terms of talking to the community as well as health economics with the study. So I think kudos to Susan, and I'm sure there are many more medical students across the country who have good ideas and need an outlet for that. COVID surge gave us made everybody a researcher in the world, and COVID was extremely while debilitating, but then also an opportunity to do research. And surgery was one of the first casualties of the pandemic. In the beginning of the pandemic, sometime in March last year, we did a modeling study which estimated the elective surgery cancellations across the world by the end of the year. And the number that we came up with was about 28 million operations will be cancelled or postponed, and which includes 2.3 million cancer surgeries. By November, and we were being very naive about this, by November, this number had increased from 28 million to almost 80 million operations. After that, we gave up the modeling study because the pandemic is just on. I'm not sure how we will catch up over the years in providing surgery to people who have had cancer surgery, and what the outcomes in cancer will be for patients whose surgeries have been cancelled or delayed. We did a study on COVID surge cancer. We initially evaluated the 30-day complication rate following cancer surgery in the COVID-19 pandemic. And then we did multiple surgeries, and we are looking at publishing our final data across the world in the Lancet very soon. And when we were discussing this, some of the researchers thought of a snapshot study to see how patients are doing in terms of surgery during the COVID times. That is, if they have COVID, what are the outcomes for a patient who's had COVID and had surgery? What are the outcomes for a patient who's not had COVID and had surgery? What are the outcomes for a patient who develops COVID post-operatively? The hunger for surgical research amongst young surgeons is huge. This was a one-week study in October. Each center had to do data collection for a week. The study was from 1st of October to the 31st of October. 122 countries participated, 1,677 centers, 1,42,815 patients were recruited over 1 month. This is one of the largest snapshot studies done, or cohort studies done in the world, and if not the largest. And there has been some talk of even looking at the Guinness Book of World Records to see whether this can be done. And you can see a large majority of countries across the world, including India, have been involved in it. In India, about 65 centers took part in this study. The great thing about this, in most of these centers in India, the study was led by student researchers or young surgical registrars rather than old consultants like us. And it has been an unqualified success. COVID Surge Week was the first bit of hard data which told us when surgery should be performed after a COVID infection. So what we came to know is that if surgery is performed 7 weeks after a COVID infection, then the mortality and morbidity rates fall down to almost normal levels, or somebody without a COVID infection. And we published this in Anesthesia, and it is one of the highest altimetric papers now in the world. COVID surge gave us some huge research base, and we worked a lot in COVID. We looked at how to manage patients who are going to doing surgery, who have COVID. We've also made guidelines on how to do surgery during with our papers, even after publication, we start looking at developing guidelines. So now we have guidelines for preventing surgical site infections. We have guidelines for surgical care during the pandemic. We have even guidelines for trauma surgery now, which will be published in the British Journal very soon. In 1.5 to 2 years, the team here in CMC Ludhiana has been able to spread the work that was with 6 centers in India in April 2019. In August 2020, the number of pins across the country is increased, and this is in August 2020. I still have to look at what 2021 is, and we have the number of centers become huge, both for global surge work as well as COVID surge research. Yesterday we had an initial talk with the University of Colombo, and we are hoping that the Indian hub here in CMC Ludhiana now will spread their work to SAARC countries, especially in Sri Lanka, Bangladesh, Nepal, and maybe Bhutan. We finished our funding in the beginning of this year in January. COVID was there, nothing was happening, but the National Institute of Health Research decided to extend our funding till September, till we get till they tell us what to do next. So we were at a sort of end of a good thing. It was nervous times. We had put in a refunding bid. And earlier this month, we've got the information that the Global Surge Research Collaborative across the world now has been funded till 2026. We are only one of the 4 research collaboratives in the NIHR which have been funded this year. And all of that has been due to a lot of good and hard work done by the team here at CMC Ludhiana as well as across the country. But when we were working in our first cycle, we were at best as sort of a startup. With refunding comes more responsibility and how to sustain the research collaboratives. So new goals have to be identified and new objectives have to be met. And one of the objectives that we thought will sustain a research network is training. That is training the next generation of surgeon scientists and research managers. We have already been providing bespoke and tailored training for individual unit studies or in-person or open access online training modules in various aspects of surgical research. But now we need to go beyond that. One of our sort of a training research project is EAGLE, which is developing a safe anastomosis program in colorectal surgery to decrease the incidence of anastomotic leak following a right hemicolectomy. And it's like the WHO surgical safety checklist. It's the surgeon and the anesthetist and the nursing team go through a checklist to make sure that none of the steps have been missed, especially with younger junior surgeons who are starting their career. There is a pre-operative risk scoring, and we hope that this will decrease the amount of anastomotic leaks that happen after a right colonic resection. Right now, this particular surgery is paused in India because of the second wave, but we hope to start off very soon. The other thing that we looked at in training was to develop our own projects, and Giraffe is a homemade project. We have already looked at perioperative care, intraoperative care, but we started thinking, why not about post-operative care? So we are now looking at a subset of patients undergoing emergency surgeries in abdominal surgeries in low and middle income countries, which we consider high-risk group, and to see whether an online multidisciplinary training package reduces 30-day mortality. And this package is focused at improving recognition and management of the deteriorating post-operative patient in the ward. The training package will be delivered to the surgical team, which includes the surgical resident, the surgical consultants, the interns, any medical students associated with the surgical team, the nursing team associated with the surgical team, the operative team also associated with the surgical team. So it's the entire team and not just one surgeon who will be trained in this package. We are incorporating adaptive learning and artificial intelligence to develop this package, and we hope to have this package at least somewhere up and running by September, October this year. The good thing is that this entire project is made in India. This is something that we will develop here in India, and this is something that we will take to the other countries across our network, and if needed, to other low and middle income countries. And you would be very glad to know that it's not just made in India. This project is made in CMC Ludhiana. Every second, third day, young surgeons here in CMC Ludhiana, along with other partners, Ritu and Parvez and everybody, are having brainstorming sessions, our nurses, Sagita, to develop this package and develop algorithms on delivering this package. When we were doing Falcon and Cheetah, we also found out that there is need to see what happens after the wound infection. What is the resource that is used by patients? Because doing the surgery, having a wound infection, just documenting that is not enough. We also have to find out how patients are suffering because of that wound infection. And 70% of the global population is at risk of catastrophic expenditure if surgery was needed. Cost of surgical complications significant to both patients because they remain out of work, there's additional treatment costs, society has a cost, and health systems which are not very robust or well developed because they collapse. And we've seen that over the last couple of years, how health systems which are weak have collapsed very easily. If no universal healthcare, like in many high-income countries available, this becomes a huge problem. And there is little data from LMICs on patient-level costs. And so we started doing a study called KIWI, which is Key Resource Use in Wound Infection. And we should be out with those results very soon. And from there, we moved on to looking at economic analysis of patients who are undergoing surgeries. So if we consider the opportunity cost when we decide to invest money, why should an administrator invest money in surgery? Everybody used to tell us that surgery is too costly and there should not be any investment in surgery. It is the other way around. Surgery actually is a very cost-effective intervention in improving health. And in fact, it is more cost-effective than giving antiretroviral therapy for HIV. So the key objectives of an economic analysis, and we have to get data to tell our policymakers this, to tell our administrators in hospitals. So if I have to tell Dr. William in CMC Ludhiana to invest in surgery, if he was not a surgeon, but to invest in surgery, I have to give him data which will convince him that investing in surgery is cost effective and much more cost effective than many other parts of healthcare. So the key objective of our economic analysis is to promote efficient use of healthcare resources and to get maximum benefit out of it. And we started doing economic evaluations alongside all our trials. We do a comparative analysis of both costs and consequences. We looked at the costs of an intervention and the benefits of the intervention. Surgical trial may demonstrate, intervention may demonstrate clinical effectiveness, but if it is not cost effective, it makes no sense in a low and middle income countries. And so our second objective in our journey till 2026 is to set up a health economics unit. We are presently in talks with Birmingham as well as the London School of Economics to develop a health economics unit here in CMC Ludhiana, which will service both India as well as the SAARC countries, which will involve evaluation of both micro and macro health economics and give health economics trainings to surgeons and anybody else who's interested. And then we work towards a policy and implementation committee, which informs national, international policymakers, as well as units who are doing further research on what is economically viable. The third thing that we have done here is we are trying to develop a management training center. Surgical research or any kind of research requires extremely good management of research hubs and research spokes to give clean, honest, robust data. It's a busy slide, and I'm not going to go through all of that, but this is something that the Management Training Center, which is again being developed here in Ludhiana, as well as one of our partner countries in Africa. And you would be we are very proud to know, and I'm sure you will be very proud to know that our very own Atul Surai is going to lead the Management Training Center, his MBA degree finally coming to some use. And he will be one of the leaders, and he has been doing this now for the past 1 year or so, doing management training for various research hubs and networks across our collaborative. And that brings us to what is going to happen this morning is the data center. All of this now works through the data center here in CMC Ludhiana. I'm very grateful to Gagan and to Dinesh for giving the space and being extremely interested in developing this data center, and to Dr. Jairaj and Dr. William, who have been extremely supportive about this. So the data center's objectives, other than developing the health economics unit, the management unit, is also training and research for medical students. As I said in the beginning, we are preparing the next generation of surgical scientists. We look at postgraduate training and research beyond just surgical audits. We are proposing a PhD program in global surgery, and you would be very surprised the amount of global surgery departments that are there across the world in the best universities across the world, both in the United States, in the UK, in Europe. I'm sure in Australia as well, there are many global surgery departments. And we support faculty for research and module development. Now, this data center is not just meant for somebody in CMC Ludhiana. It is meant for anybody across the country, our partners or anybody else who's interested. So if Robin is interested in doing a project, we connect online, we help his team, or they tell us what to do, and we do that and return back the analysis, etc. At the same time, we train in medical students, postgraduates, and we hope that some of them would take up research as one of their goals in their career. The other thing that we have looked at, access to surgical work stream. Access to surgery is a major problem, and we are working on surgical care work stream, which will improve access to surgery. So we're looking at, we've done systematic reviews, we have done interviews, we've done an economic module, and now we are moving on to see, for example, how easily it is for a lady who's pregnant and needs a cesarean section to come to CMC Ludhiana to get the cesarean section. Does the auto or the ambulance take her to another hospital where there is no cesarean section facility, or there is not a neonatologist available? So those are barriers that we will be looking at in our access to surgical care work stream. We worked with our mission hospitals in the last 2 years, and we realized the wealth of information and the huge amount of work that our rural surgeons have been doing quietly, without any fanfare, and with no voice. And one of the objectives of the new refunding of the new cycle is a separate rural surgery research network. I'm taking these words from Philip, whose photograph is there, and I'm sure a lot of you know Philip. Rural surgery is a changeling. It's a concept, but no definition. And the objectives of the Rural Surgery Research Network would be education, both surgical education as well as research education, sharing resources with bigger institutions like ours, or Vellore or AIMS, research impact policy, which is directed towards the rural community, administration, and finally the impact in the community. We are now hiving off the Rural Surgery Research Network as an independent network, which will be led by Philip and Deepak and Arpit, and people who have been doing some absolutely amazing work in the field. Another thing that we have now started looking at is community engagement and involvement. And we have started, rather than Dhruv telling that this is a good idea, Dhruv thinks it's a good idea, it might not be a good idea. So we're now looking to go to the community and asking them, what is a good idea for research? What affects them that should be changed, rather than what I or somebody at my level decides. So we are trying to turn everything 360 degrees to start research by talking to the community first. And we are now in the process of developing a community engagement involvement, or what we call a CI network in India, which we've been in talks with Deepak and Chinchpada to lead, and because we feel that it should develop from our rural hospitals rather than posh urban hospitals. This is something that we did with Susan's work in abdominal tuberculosis, a little bit of community engagement and involvement. This is one of our patients who Susan had collected the data for, and Ritu here, who's been very actively involved in community engagement involvement. Yeah. So I'll tell you what she's talking about, her experiences with abdominal tuberculosis and abdominal obstruction, intestinal obstruction, and how she had to be in and out of the hospital. Her fears, her expectations, how life was set back, and what she wants to be changed. And she's a 18-year-old girl. She's gone to dental college recently. And what she would want us as researchers to look at, so that children do not suffer from the same problem that she's had. Our research output from 2019 to now, and again a busy slide, and I think a lot of us here in CMC Ludhiana, as well as our partners, Robin's team in Kolkata, and if I'm missing somebody, pardon me, but everybody else here has been involved in that. We've been very grateful, and it's been a huge amount of hard work that everybody has put in. Everybody has been extremely comfortable, or nice rather, in working with us. And we have published in high-class journals, right from Lancet down to anesthesia. And we hope as we continue that this will continue, but this is not the end all. It's just a step, the research output. Till we change things at the ground, this slide is a waste. Looking ahead, we are now going to devolve responsibilities, especially administrative responsibilities. Very difficult to manage a country like India from. We are now in the process of opening sub-hubs in All India Institute in Jodhpur, in the Tata Medical Center in Kolkata, and CMCL-Global, which will manage their areas. We will be looking at managing the northern part of the country and hopefully work towards developing our projects in our SAARC neighbors. Also, we are now looking at various collaborations. We've already started collaborations. Gagan and Monica have done research module development for the University of Oxford's Global Child Non-Communicable Disease Collaborative. We have worked with the WHO Collaborative Center for Surgical Care Delivery in LMICs. One of our students, Sahir, has been instrumental in doing some research, and we're hoping that will get published somewhere. We have an extremely intelligent bunch of medical students in CMC Ludhiana. When I look at some of the things that they tell me and the things that they have been doing, I wonder what we were doing when we were medical students. So we've been put in touch with the Asian Medical Students Association by Rohini and an organization called Incision, which is an international student surgical network by Rohini and our friends across the country. And we hope to work with them also to develop projects with young researchers. What we want to do is ask our young people to continue to ask questions. So there's Moloti there, who's a young surgeon who's working in Makunda, who's one of our partners, to ask questions, to devise research projects and to lead those research projects. While we as senior people are just are facilitators in this. We move away from being PIs and we let the younger people take the lead. And I think it's very important if surgery and surgical research has to develop, that our younger people have to be given responsibility and the responsibility to take the lead, because they have some very good ideas, and it's criminal to not let those ideas come out. This is our team here at the hub. I have been an absent member. I think a lot of or rather 99% of the work has been done by this team here minus me, and the success of global surgery in India. We've been voted as the best performing hub across the country. And global surgery, the Global Surge Research Collaborative is now the largest surgical research collaborative in the world, beating places like Harvard and Johns Hopkins, etc. And this team is the team which has worked day and night to get this thing up, running, and so successful. At the end, I would like to thank two people. They look very similar. They look very sharp. They are not looking very sharp all the time, but these are the two people who have been instrumental in pushing things, Atul and Parvez. Parvez, in this new funding cycle, takes over as the hub lead from me, while I move on to roles which are less stressful. And Atul has been managing everything across India and even in the rest of the world. Thank you for listening on to me. I hope I haven't taken too much of your time, but I'm ready to answer any questions.
Thank you, Dr. Dhruv, for that excellent presentation and giving us an overview of the work that Global Surge is doing. Before we have a kind of question and answer session, I'd request Dr. William, who is there in the audience, to give his comments and, Dr. William.
Thank you, Dhruv, for looking after neglected stepchild of global surgery, global health rather, that is surgery. You have not only looked after, you have taken it one step ahead at international level. So congratulations, and On behalf of our institution, CMC Ludhiana, we are grateful to you for your efforts. You have recommended certain guidelines for future. I'm sure in next presentation, you would like to highlight what is the outcome of those guidelines which you have introduced, your studies has introduced, and all those projects which are going on as far as economy is concerned, making treatment cost effective and approachable to all spectrum of society. That will be nice to observe in coming, I would say, a few months. Since you have collected a lot of data in last 2 years, so it's time to get benefit out of it. For that, data center has been set up, and it will be useful not only for young scientific surgeons. I am sure there is no contraindication for joining other surgeons as well, which you may label them as a old or of previous generation. All of us will be benefited, and it will bring new changes to the health system, particularly surgical health care, which we are providing. And today, Dr. Sarish is also with us. Thank you, sir, for joining us for Grand Rounds. And soon after Grand Rounds, we'll be joining to inaugurate our Global Surg Data Center, which will be used by our students and all those who are working in rural surgery. Once again, thank you.
Thank you, sir, for those comments. Dr. Dhruv, there are plenty of messages in the chat box congratulating your work. Most of our alumni are proud of the work that you are doing through Global. We have Dr. Robin in the audience. Dr. Robin, would you like to give your comments about the work that is happening here in CMC through Global Surg? And Dr. Harish, Dr. Harish also is there, our alumni, both of them doing great work in their centers.
We got onto the Global Surg Collaborative, I think, close to a year ago, if I'm not mistaken. And I could see firsthand the amount of hard work behind the scenes that goes into actually making this. So first, a big congratulations to Dhruv for what is an absolutely phenomenal effort. And in fact, when we have the Global Surg meeting, I think when we've had occasional Global Surg meetings, I think the people in Birmingham have a lot of praise for the India hub, and I think it's a lot due to the hard work by the hub, Dhruv and Atul and everybody else at CMC Ludhiana. So we have, I think, 5 Global Surg research studies going on here. We have involved mostly our junior consultant surgeons to do it. And it has been a very, very enlightening and an enriching experience. So we're looking forward to further collaboration, and we're still waiting for Dhruv to visit us.
Dr. Harish, you there?
Dr. Ashish. Dr. Ashish.
Okay, I think he's not there. So I'll give my comments, and it's a great effort, and so much has been achieved, and it's for CMC. This is one of the greatest academic and research achievement, and I'm pretty confident that it's going to grow further and expand not only in this country but also the Indian subcontinent. And I also want to emphasize here the opportunity for medical students and interns. I think this may not be available for other medical colleges in our country. There are more than 450 medical colleges in our country. So I now all the medical students and interns to utilize this opportunity and put your energy in a proper way, and that will be useful for your future career. Whether you are going to work in a mission hospital or you want to work in the private sector or public sector hospital. These things, if you learn during your undergrad time, which will really help you to grow later on. Thank you.
Hello. We have Dr. Sirish also with us. Dr. Sirish, you've been one of the senior alumni of the surgery department here. Would you like to give your comments about the work that has been happening?
Sorry, I couldn't hear you. Can you repeat the question, please?
Yeah, sir. You've been a senior, one of the seniors from the general surgery department. Would you like to please give your comments on the work being done through Global Surg?
Well, this is all very new to me, but I can see Dr. Dhruv is very passionate about it. So honestly, I've been sitting here for almost an hour and I'm just beginning to understand it. So I think it should succeed. Yes, it's a good idea.
Thank you. Thank you, sir, for those comments. Thank you, everybody, for joining us for the grand rounds. Next week, we have Dr. Vinay Gaikwad from Gurgaon. He will be presenting his work on the oncology that he's doing.
Frozen आने वाला है तो शायद मैं ना आ पाऊँ.
Medical oncology. Thank you, everybody, and have a good weekend. Thank you.
Grand rounds. Oh, shit.